image, na sir? MRI.
Yeah, the MRI image.
Yes, yes, yes.
So we'll till this start. We'll discuss this case. Okay, did 2 days ago.
Okay, sir.
So he's a 56-year-old gentleman. Okay,
Okay.
can you hear me?
Yes, yes, sir. We can
Yeah,
hear. Please,
yeah.
sir.
So he underwent. He's a known case of diabetes and hypertension for last 10 years, on regular medication, and he underwent angioplasty for coronary artery 4 years ago. And that time the angiography was done from the right radial, and even the stenting was done from the right radial.
Hmm.
And 3 years ago, he developed some hearing loss. Okay. So the MRI was done, and MRI was normal, except that the right CC and IC was completely blocked. And this time he presented to me with a 2 or 3 episode of blackout. Both episodes were 3 episodes, all were in the standing position, and one episode while doing some puja at home, lasted for a few minutes. Okay.
Okay.
So this is the MRI. I think the titulated images, which was perfectly normal.
Yes, sir.
Again, I'm going to show some photos. Now the second image, you can see the flare, which is normal.
Okay.
That is the MR angiography. So this MR angiography, the intracranial circulation showing the you hardly see any ICA.
Yes. Not
Okay.
see. Please see.
Yeah,
Yes.
the left IC is okay. You can see that again intracranial IC is reforming. Looks like from the PCA, PCOM, okay, and then NCA. Anybody appreciate that?
Yes, sir. A1 is not that clear, so probably.
Yeah, A1 is not so clear, so it's probably filling from the posterior circulation.
Yes.
Okay.
Yeah.
We can see the big left vertebral artery, hypoplastic right vertebral artery. Okay.
Right. Yes, sir.
Yeah. This is the neck angio. Okay. So neck angio is showing brachiocephaly. Then you hardly see any CC and ICA. Right hypoplastic vertebral artery, good left vertebral artery, and again there is a left proximal ICA stenosis.
Yes.
Okay. So what are the differential in these patients? And when I examined him, his right radial was feeble. Okay, there was gross difference in the systolic pressure between the left and right. Okay, arm. Okay. So now question is what we should think in this patient. Is bilateral, like the one right IC is totally occluded, left is severely stenosed. That is the culprit. Second, that subclavian looks like okay, but there is some stenosis which is creating a problem, but the right vertebral is hypoplastic. So is it contributing in the circulation or not? So what do you think in this case? What should be the next investigation of choice? We should go for the long halter patient can have, okay, some arrhythmias, or should we go for the tilt table test? The second and third, should we do go for the DSA in this patient? ECG was normal. Echo was okay, around 56% ejection fraction. On examination of OPD basis, there was no postural fault. So anybody wants to comment, please, on your mic and give your output input in this patient.
Sir, is it a large cell vasculitis, large vessel vasculitis like Takayasu or something?
He's 56 guy. He is hypertensive, diabetes. Why you are thinking of the Takayasu in this patient? See, he is not middle-aged female. He is not young-aged female or male. Why you are thinking of Takayasu in this patient? Having all the risk factor for the atherosclerotic artery disease, and having the proximal ICA some stenosis, the significant stenosis in the opposite also. Oh, sorry, I forgot to give one more input. He had a nasopharyngeal carcinoma, okay, 10 years ago, and he was treated with the radiotherapy. Sorry for that.
So whether the lesion is chronic or acute will be the first.
The first, the ICA is or CCA, right? ICA or CCA is chronic because 4 years ago he was investigated for the right ear hearing loss, so that CCA was not there on MR.
So probably after acute coronary syndrome, he might have started on some beta blockers or vasodilators. So probably he will be getting some hemodynamic decompensation of the chronic lesion, which is right total occlusion and left ICA stenosis.
Is a culprit, is it?
Then we have to rule out the right subclavian brachycephalic.
That is culprit because left is so prominent, equivalent to like the size of left vertebral is nearly equal to the ICA. You can see, you can appreciate on MR. So is that patient is in the first thing is the patient is having the VBI. Second, the patient is the cardiac syncope. Third is the patient is of the postural syncope, and fourth is because the patient is a bilateral ICA is causing syncope-like episode. So, which you think is the first differential diagnosis in this case?
The symptom was blackout, no, sir? Yes.
Blackouts. Yeah, clearly the darkness in front of eye and some instability in its core. And the third episode, he was doing some puja. And one episode, he came out from the car and he had some. And the first one, he was going to the for giving his blood sample for the investigation. The first happened at the hospital or nursing home. Second, while he was coming out from the car. And third, like doing some aarti or puja at home.
Symptoms, sir, maybe due to this left subclavian, there was also stenosis is there.
Yes. So
maybe steel phenomenon occurring.
But the size of vertebral is very small in this case. Can you see?
Yeah.
Okay, I'm zooming it. Can you see the zoom?
Yes, sir.
Yeah, it's a very small. But yeah, this is possibility. And would you like to keep that one first? I'm giving you repeatedly, doing puja, arti. So anybody is doing the puja, we are using the right hand. Okay.
Yes, sir.
So I don't have the angio actually. So when I did the angiography, that was my first shoot was the from the left subclavian, and it surprised me. It was a good still, even that right vertebral is hypoplastic. Okay, but I can see this the blood is coming retrograde from right vertebral and for reforming the subclavian and going in arm. The second, even the left vertebral is so big, whole MCA or the right side circulation is supplied by the
Left vertebral.
basilar, yeah, from the posterior circulation. So half of the brain is getting, or posterior circulation is getting blood. Even the right arm is getting the blood supply, not completely from the left vertebra. So he was having the actually still, okay, and definitely he is having the left IC stenosis also, but it is not culprit. If you see the MRI, there is not even a small lesion in the brain. Okay. So in this case, I did first subclavian. It was severe. So I did the first subclavian, and here in the subclavian, I don't have that right now. All the carotid or subclavian stenting photographs. So I did the first the subclavian where I put coronary stent because it was some tortuous. So self-expandable stent. Size was 7, 10, 40, 40 protage. So before placing the stent, I have to do the pre-stent angioplasty, which was done with a 5x18 balloon. Okay. And then I placed the stent. Then post-stent plasty, I did with the 7x18 peripheral balloon. Okay. Then after the subclavian, I did the ICS stenting. Yeah, the second thing, so which should be done first, like IC or subclavian? Anybody? Hello?
For stilled,
No, even suppose you want to do both and you are not sure which is symptomatic. Okay, even you are sure the left IC is symptomatic and right is severely and having the still, or you want to do both the stent, you want to put both the stent in a single procedure. Which one you like to do first? Subclavian or IC?
Subclavian, sir.
Why?
So one reason is the vertebral is supplying multiple areas, including the right hemisphere. Another one is
No, I'm not discussing about this case. I'm discussing the overall, like in this case, definitely because looks like this is the culprit because of the still, and the symptoms were more related to the posterior, like VBI kind of or plaque out. That is very, very unlikely with the anterior circulation. If the left IC is culprit, then patient should have some speech arrest or right side hemiparesis because it's not contributing the right side circulation because the ACOM is not good. Okay. So that is a different thing. But overall, like you want to do the somebody in the severe subclavian stenosis with the similar or having the left ICA and want to do the because of the financial region or some other region where you want to do the place a two in the two stent in the both the arteries. Which would you like to do first, the subclavian or ICA? Subclavian we will do the first. The complication rate with the subclavian is very, very low. Okay. Second, the vertebral is flowing retrogradely. Okay. So the blood which is going to go up with the hypoplastic artery is very less. The chances of embolization from the subclavian to vertebral to basilar is almost zero. Because the flow is totally retrograde. Okay. Third, in this case, I want to place and cover the right vertebral ostia also. So anything should not go up. Okay. That is the third thing. And the hemodynamic instability is unlikely to happen with the subclavian artery, which is very common when you're doing the ICA. Okay, when you will do the ICA, there's always a bradycardia or hypotension. So doing the second stent may be a problem. Okay, so I prefer to do the subclavian first, which I did in this case, and immediately I did the left ICA. Okay, using the same catheter, then using the filter, then place a stent, did the plastic. Unfortunately, I'm not having all the picture right now. Did day for yesterday only, and today patient was discharged. But having the MRI picture, so I was sharing it. So the case is ready now.